Hello everyone, my little burgers, you all right? Right, just a quick one today. Well, always say that, but it ends up waffling. So, hi. Anyone don't know, I'm a stroke survivor. We discuss issues that I experience, what's gone on in the day, but also some random stuff every now and again. Oddly, sometimes some politics, oddly, something else. It just depends what I want to try and event and get rid of. But if you're new to the channel, welcome. My name's Wayne. Lovely to meet you. Please sign up, do what you need to do the loves, do the heights, do whatever, dicks, whatever. Today was a good day, a really good day for me and for Lizzie. We have an interview today with a TV program that will be coming out in the future. And if anyone doesn't understand, I promote BEFAST, not just FAST, which is balance, eyes, face, arms, speech, and time, because it's quite imperative of why. But we discussed this, and my story might be coming out as part of a 4 series program. If it does, fantastic. I'll let you know the dates, the links, everything. If it comes off, I'm just waiting for them to. They've only just finished today, and they're going away. They're going to write it all up, do what they need to do, blah, 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 edit, blah, 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 blah. But once I've got an idea when it's coming out in the channel, I'll let you know. Yeah. But generally, it's not just about myself. It's about others and other young stroke survivors and about their experiences and what they want all to do with like BEFAST from what they've been discussing about us today. So it was a good day for us because we're trying to spread that message out to the wider audience and clinicians and many others, right? Just to change the perspective of FAST, how FAST can affect others, but how BEFAST could save others, and the knock-on effect, and how a quarter of all stroke sufferers have rear occipitals, so they suffer visual and balance problems as the main part, which is the B, which is missing from FAST. So it would be BEFAST, so balance, eyes, face, arms, speech, and time. Now, what I've always described is strokes change with the person and whereabouts it is in the brain that the clot or the bleed happens. So it affects different people, different ways, different symptoms, different signals. These all change dependent on where or how the stroke is occurring. Now, I had a rear occipital ischemic stroke. Some people have a bleed. I had a clot. My treatment, I didn't get the thrombolysis or thrombectomy because they don't do it in my area. So this changes how it affects me. But we were discussing why BEFAST is important in my case and my experience. And we've gone from there to try and help others, hopefully, in the future. So it was fantastic for that. So when it all comes out, that'd be great. But it makes you open up and talk about things that you might not have been aware that you were holding on to. Like mine is I'm very angry with what happened to me because of what I went through, what happened at the hospital, and the lackadaisical non-urgency that came from a suspected stroke, where if I'd had the fast symptoms, if my face had drooped, my treatment may have been far quicker and I may have got the thrombectomy or thrombolysis, sorry, because they don't do thrombectomy in this trust, which is scary. So postcode lottery, if you get the right trust, you get treated better. Like I said, my cousin, who about 10 weeks now had a stroke, he had the thrombolysis and he's almost back to normal. Yeah. We had Lizzie's colleague that said the same about one of her family members who had a stroke in London. He got treated so rapidly that he was back to work the following week. This is the difference between strokes and symptoms and how time critical everything is. So it even says it in FAST, it says it in BEFAST. Time is critical. So the diagnosis of your stroke is time critical because it changes how the stroke affects you. My stroke got worse the 24 hours after the first moment it occurred, and that was whilst I was in the care of this trust. So my symptoms of what I've left with now came from them, because if I would have been lucky to get the treatment I needed in the time frame I should have been, because I was there quickly, I would have been fine. And it's all down to their records. So it's all there. So it's all logged. So I'm not telling a lie here. I was at Ashford in quick enough time. The processes to get me from Ashford to Canterbury were what delayed. It took 4.5 hours, I believe, from what we have talked through and walked through today, from presenting there to there. It was just over the time frame from getting thrombolysis. So that shows you how different things happen. And this is the difference between me and my cousin. I was what's known as FAST negative, which means I had none of the symptoms. So face, arms, speech. Yeah. Where my cousin did have some of these, right? So he was in the Midlands, I'm down south. Because I was FAST negative, they didn't believe I was having a stroke, even though they were being expressly told I'm having a stroke. When they finally admitted it, it was too late. It was too late to do anything. I'd gone past the time frame. And then by the time they finally got an ambulance to me, it was well too late. 2.5 hours for an 18-minute call time is too late, right? It just wasn't urgent enough. That's what's affected mine. But hopefully this will come out in the documentary that people will see, and hopefully it will make change on the whole grand scheme and bigger picture of things, because we need to make a change. We need to change people's attitudes. It's not always about the fast symptoms, it's about the symptoms that you don't know. And clinicians need to understand that. Clinicians are important to understand that. If they don't understand, they don't understand the differences between certain things, that's a problem. Like we researched today, a quarter of all strokes are rear occipital, so they don't show up with fast symptoms. They show up differently. So 1 in 4 people are going to be misdiagnosed straight away because they don't know the BEFAST. They only know FAST. So if you're FAST negative all the time because of where the stroke occurs, 1 in 4 people are going to slip through the net. That's a large quantity. 1 in 4, not 1 in 10, not 1 in 40, 1 in 4. That's massive. I looked at the total cost of strokes that cost the NHS. I think it was 9.6 billion a year for strokes. Now, if we subdivide that by a quarter, it's 900 million for the quarter numbers for rear occipital strokes, right? That's 900 million. Now, if we could save half of those, that's 450 million less cost to the NHS. Wouldn't that make sense? Makes sense to me. Commercially, it makes sense. So when you had the NHS Scotland, NHS England saying they don't want to inundate the front line, that's rubbish, because the back end costs, like I've said before, are huge. It costs more for, like, I think per patient, it was like £18,000 per person, and 13,000 of that was the first initial care or something. I'd have to double check the figures, but that was roughly what we researched and found. That is for the knock-on effects after having a stroke. Yeah. And most of that is just the initial care afterwards. The long-term effects means it goes up to like 18,000 to 13,000 was just after it happens. Well, imagine if we caught it before they got to that bit. So rather than being post-stroke, it was pre-stroke and it was diagnosed straight away. That would be £18,000 saved per person, right? So that's for a quarter of them, right? Now, you get 10 people like that, that's £180,000 a week. If that was 10 people a week, that's £180,000 a week we could save per trust per time, right? So these numbers aren't small numbers, these are huge numbers. This is why the NHS has these extra costs, because we're not saving people. We're actually causing more problems for the NHS because they're not being diagnosed quick enough. And it goes, I'm only talking about strokes, but we was talking with the young lady today. They done something about breast cancer in young patients. Now, I'm classed as a young stroke survivor because I was working age, right? Now, these breast cancer patients were all young patients, some of them like 26, 20 odd. They're in their 20s. They're getting more and more at that younger age. Now, if they're being missed, right, we need to change that as well. So it's not just strokes, that there needs to be changes to policies and procedures, because they are victimizing, discriminating against people that are showing signs of stroke. Even any potential signs of stroke or breast cancer or anything needs to be investigated properly at the front line. Now, if we don't educate people by our clinicians and others like the paramedics and everybody that's involved before, including 111, right, because they just read off a script half the time. Well, if they do that wrong without seeing a patient, that's a bit wrong, right? Now, 111 will send people into an MIU unit or something like that, minor injuries or whatever they're called now, I can't remember, for the stupidest little thing that they don't need to be there for. However, because someone might be FAST negative, they wouldn't send you there at all because you don't tick a box. Yeah, face, no. Oh, no. Arms, no. Oh, speech, no. Oh, well, we can't send you because you're FAST negative. And that's relying on someone that can't see you, hear you, visibly touch you, and yet they're supposed to direct you where to go. Sorry. Up front, in front of a nurse or a doctor that can assess you and see the changes in you, is important. 111 does okay, but it sends stupid things to places they shouldn't be. So they send people to A&E when they shouldn't be. But that's the problem with having a script. You use this tick box, you use that script, you miss more because you're not asking the right questions. Yeah. Now, they used to use clinicians, but nowadays they just use people to read off this sheet. You've got to read this, you've got to read that, that's it. Well, that comes down to how someone describes their symptoms as well. You can't, I might go, what's your pain threshold to me? And I might go, this is only about a 2, it's nothing. Right? But someone else might go, oh, it's an 8. Oh, I'm so terrible. I feel so bad. When in fact, for me, it might be nothing. But then there might be one where like they go, what's your pain? And I might just go quiet. Now, my wife knows straight away if I go quiet, it's painful because I'm trying to focus out the pain. I'm trying to let it go. And all these things make decisions difficult. The problem with 111, you can't see a patient, you can't smell a patient, you can't see the sweat, the colour of a patient. Now, relying on someone to describe someone makes an error, but a clinician seeing someone face to face, they can make a better assessment. So I understand why 111 sends people, because if you're being told something, but you can be inundated by people that are just manipulating the system to get what they want. Well, they're the idiots that are costing us so much money, and they're actually costing people's lives. We're getting back to like the strokes and other ailments. There's obviously cancer patients that are missed, and there's other illnesses that are missed, like dementia and other things that are just missed because perhaps a clinician is having a bad day. Perhaps the doctor's having a bad day. Perhaps they're stressed. Perhaps the procedures have got issues. Perhaps the trust is kicking off and they're sending out all these messages to doctors and nurses and creating issues for them. All those external factors could affect you getting diagnosed correctly. Now, we need to be open and be smart enough to go, we need change. We need to say no to that. We need to make sure that we have something in place, which is all we're asking for with the strokes. Be fast. Yeah. Balance, eyes, face, arms, speech, and time. If we can get that out there in front of the clinicians and others, it could make a huge difference, a massive difference, but not just for the stroke sufferer, but also for the family. Yeah. Sorry to go on, guys, but that's what this was about. Yeah. But I'll come back later on another one and we'll discuss um, your disability needs and the tools that you need to use. Like I use a cane every now and again, a walking stick. I've got these glasses, right? Now, I don't know if you know, but Meta Ray-Bans. I use these sometimes because I can't read certain things out, right? So these will do it. I don't understand certain things fully, but the glasses will do it for me, which is quite useful. I've also got I'm going through it anyway now, aren't I? A kettle that has 1 cup dispense. So you press it, it just does 1 cup, doesn't overflow. Like where some disabled blind people, they use a sensor that's like this big, sits on the cup, pour water in, and it lets you know when there's beep, 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 when the water's touching it. So you stop pouring the water. This is things that occur, right? And people need. Do you have a cane? Do you use a small, thin, white cane that you just hold? Or do you use the one with the roller ball? Or do you use one with me that has got a wheel? Or do you use one that's got a big flat that can go over rough ground and terrain? There's so many variations to what you use. Have you got a guide dog? Have you not got a guide dog? Do you use other symptoms? Do you use clicking to sense where things are because you're blind, because I'm partially sighted? There's many things that people use that people don't understand we use. It's like you might see someone partially sighted with a mobile phone like this, but they've got accessibility tools on that phone that allows them to see the screen or they read the screen out for them. Now, I've seen many pictures on Facebook where you've seen this woman like walking along with a cane but looking at a phone. Yes, she might be. It might be enlarged that much that vision that she has got might be able to see something. Yeah. These are the sort of tools that people don't understand because if you've not got a disability, you don't understand the tools that are out there for people to use, but you are judging them because of their disability, but not in a good way, in a bad way, because you think they're doing it for some reason. Yeah. That's another subject matter. Yeah, we discussed that today as well. And the people that I was talking with, a solicitor and a producer or something, they were shocked at some of my experiences from the normal public and how people treat disabled people. Yeah, but that's it for today, guys. But my little burgers, be kind, be safe, be friendly, be fast. Oosh, my little dudes. Take care. Love you all. Bye.